Hey everyone, welcome back. It's Mike Mutzel with High Intensity Health, the best of fitness, nutrition, and functional medicine. I'm so glad that you landed on this video because we're going to talk about functional GI disorders and a common condition known as small intestinal bacterial overgrowth, also known as SIBO. SIBO is very common. It's linked with many systemic inflammatory issues, autoimmunity, neurologic disorders, cloudy thinking, failure to thrive, even obesity and diabetes. There's links with that. So we caught up with none other than Dr. Sandberg-Lewis. He's written a book on functional GI disorders, a handbook for clinicians, and he also founded the Small Intestinal Bacterial Overgrowth Center for Digestive Health in Portland, Oregon. This is the only center of its kind in the world, I believe. And so we talked about common triggers of small intestinal bacterial overgrowth. We talked about the ileocecal valve and how that can link to small intestinal bacterial overgrowth, motility and digestion and everything in between. He talked about other non-common triggers, certain medications that if you take, you need to be on the lookout for, and you have to listen to learn what those are, and also assessment modalities. He also reveals some things that I didn't know about before. For example, people that respond adversely to dietary fiber, which we all think is very healthy, they may have small intestinal bacterial overgrowth. People that actually feel good on antibiotics. I know it sounds counterintuitive. How can someone feel good on antibiotics? But you'll learn why and what you can do about it. So you're going to learn how to assess, diagnose, and treat this very common condition known as small intestinal bacterial overgrowth with functional GI expert Dr. Sandberg-Lewis. I really hope you enjoy this episode, and if you do, please subscribe to the channel so you get instant updates when we release new videos. Thanks so much.
For instance, one thing would be if a person tells us, you know, all my GI pain, my diarrhea or constipation, it got so much better when I took an antibiotic, say, for pneumonia. And wow, I was so much better. And then it's all started coming back within 2 weeks of finishing it. It was all back. That to us is a little golden little nugget that tells us that could be an overgrowth of normal flora. Mm-hmm. You know, that just got beaten down by a treatment that wasn't specific for it.
Welcome to High Intensity Health Radio, the best of fitness, nutrition, and functional medicine.
And now here's your host, Mike Mutzel.
All right, everyone, welcome back. I'm very excited for today's guest. We have with us naturopathic gastroenterology expert, Dr. Sandberg-Lewis. Dr. Sandberg-Lewis has been in private practice for 18 years prior to joining the faculty at the prestigious National College of Naturopathic Medicine, also known as NCNM in Portland, Oregon. He's been there for 18 years, so he's been doing this quite some time. And he is a co-founder of the SIBO Center for Digestive Health at NCNM and the author of the textbook Functional Gastroenterology, Assessing and Addressing the Causes of Functional GI Disorders. Dr. Sandberg-Lewis is a frequent presenter at many educational seminars throughout the U.S. and Canada. And today we're going to dive much more deep into the gut. So Dr. Sandberg-Lewis, welcome.
Thanks.
I'm very excited to have you here. So let's briefly talk about your journey and how you got involved in naturopathic medicine. You know, over 30 some odd years ago, it probably wasn't nearly as popular and as prevalent it is now. So let's talk about that.
Yeah, back in 1973, when I decided to apply to National College of Naturopathic Medicine, which, by the way, now, because we have more programs, is called National College of Natural Medicine.
Okay.
Name change. There was basically naturopathic medicine was an almost dead profession. There were very few practitioners. There was one school, and it was graduating usually 4 to 8 doctors a year. It was very, very minimal. And what saved it basically was the hippies. You know, the children of the 1960s, they found out that there was a type of physician that used natural methods and followed natural law to get patients well. And we all thought, holy cow, you know, where was it? We never heard about this. And it was a bunch of, you know, mostly older physicians that were dying out. So there was a rebirth. And in 1974, it was the first full-time 4-year day program. Before that, it was kind of a night program. And then I started in 1974. Actually, 1973 started the first full-time 4-year program. So how did I find out about it? My father told me about a naturopathic doctor that he had visited in Asbury Park, New Jersey. And I was growing up in New Jersey, and I was 18 years old, and I went and visited him, and he said, "What are you studying at Rutgers College?" And I said, "I'm studying psychology." And he said, "That's really great. You could help a lot of people, but I think you'd help even more if you understood the whole body and how the mind is just a part of the body and how to take care of it." So I thought it sounded good, and I applied, and my life has changed ever since.
Wow. Now, where did you open up shop during those first 18 years?
Well, I moved around 3 times in those first 18 years. First, I had a practice in Port Townsend and Port Angeles, Washington for about 6 years. And then I moved down to Portland because it was the home birth capital of the world, and my wife and I were planning on having kids, and we did. And then after we had both kids in hand, we moved to Orcas Island up in the San Juans in Washington and practiced there for 7 years.
Oh, nice.
And then I was offered the full-time position at NCNM. I had taught as an adjunct about 5 hours a week for 5 or 6 years prior to that, and I thought, boy, I really love teaching and helping students learn how to work with patients, and so I took that up 18 years ago, and I've been here ever since.
Good for you. And you're still seeing patients 3 days a week, correct?
Yeah, I actually see patients 20 hours a week.
Oh, wow. That's great. So once you went to NCNM, how long was it before you started the SIBO Center for Digestive Health?
We only started that about 4 years ago. Dr. Allison Seebecker and myself, she got interested in SIBO when she came to a weekend seminar that I was teaching about functional GI disorders. And, irritable bowel syndrome is the most common functional bowel disorder. When she heard about SIBO, she just started reading everything she could about it, and the specific carbohydrate diet and GAPS diet and other things related to treatment of SIBO and IBS. And we would meet every couple of weeks and just talk for 3 hours about all the things we had been learning and researching this. And eventually, I was seeing more and more patients with it. She wasn't practicing back then, and she decided after a year of doing that to get back in practice. And we decided, well, we wanted to teach more doctors about this because it seemed like doctors didn't know much about it. Some didn't know anything about it, even though it's in every major medical textbook. And doctors just didn't know what to do or even how to test for it. So we formed a center so that we could do research, do patient care, train more doctors and patients about the details of SIBO, and then also do testing. So we have a testing center so we get a good test.
Perfect. And I would love to expand more on that. But if we could backtrack just a little bit, make sure that everyone's on the same page. You mentioned 2 words that I would love for you to define. The first one was functional gastrointestinal disorders, and you mentioned IBS. So if we could define what that is and what are some common signs and symptoms, and then let's define SIBO or small intestinal bacterial overgrowth and what that is.
Okay. There is a group that meets in Rome, Italy every 10 or 15 years, and they come out with the Rome criteria for functional gastrointestinal disorders. And there are actually about 36 different functional gastrointestinal disorders that have diagnostic criteria. And they span everywhere from the esophagus down through the liver and gallbladder and throughout the small intestine, large intestine, the anus, and the rectum. So each part of the GI tract has conditions that, as we learn more and more about the details of what's underlying the cause of both, pathologies, known diseases, and the functional conditions, we find out that the line's kind of blurred. Some of the functional conditions, especially irritable bowel syndrome, the more we study them, the more we realize there really are things going on. It's not just dysfunction, it's actually, there is some disease there, but the idea is dysfunction, meaning the system isn't functioning ideally, as opposed to pathologies, true diseases that you could find changes in blood tests or doing biopsies or scope exams. Functional disorders, like I said, the most common one in the GI tract is irritable bowel syndrome. And it's a very, very common condition. And unfortunately, most physicians don't have a lot of skills at dealing with functional GI disorders. That's why I wrote a book about that, a textbook for physicians. And that's why we created this center.
Now, before we talk about SIBO, what's the prevalence in, obviously your practice is probably very high, of functional GI disorders, but in the general population in the United States, for example, how many people are running around, whether they know it or not, and have some sort of functional GI disorders? And what are some common signs and symptoms?
Well, if you just look at irritable bowel syndrome, the most common one, depending on the study you look at, somewhere between 10 and 15% of the population, and a little more common in women. But if you, for instance, look at the practice of gastroenterology, if a person goes to see a gastroenterologist, a specialist in digestive disorders, a full 40% of those patients have functional GI disorders as opposed to pathologies like diverticulitis or acute appendicitis or cirrhosis of the liver. So 40%. A really important piece here, though, I think, is that because most specialists in digestive disorders really don't have the understanding or the tools to deal with functional disorders, if 40% of the people coming to them have them, they're basically going to get drugs that decrease their symptoms, and unfortunately, they don't always work very well, and they create new diseases. So it's a sad thing, and that's why I really wanted to see what I could do to change that.
Oh, absolutely. And we'll have the link to your book on the show notes so everyone can get access to that. So we know the bacteria play a role here, and imbalances in the bacteria can contribute to the inflammation that you talked about and functional GI disorders. So let's talk about bacterial imbalances in the small intestine.
Yeah, so SIBO stands for small intestine bacterial overgrowth. It's actually, depending again on the study that you look at, one study says 84% of patients with irritable bowel syndrome have it because of an underlying bacterial overgrowth in the small bowel. Other studies have it as low as 37%, but it's still a significant number anywhere between those numbers. I'd say probably at least 70%. That means they don't really have an infection. What they have is an overgrowth of their normal flora. Normally, the small intestine has very small numbers. If you look at actual numbers, it's 10 to the third or 1,000 bacteria colonies per gram of stool in the small bowel. You get into the large bowel, and you've got billions or trillions. And that's supposed to be that way. But in the small bowel, it's supposed to be really small, and even smaller in the stomach. When that normal flora overgrows, and that might even include lactobacillus, if that overgrows, people can be very, very sick. And unfortunately, often the doctor doesn't know what's wrong with them. They get treated for all kinds of other things.
If we can name some, we're talking autoimmunity, mood disorders. What are some common things that you see?
You mean the kinds of symptoms they would have? Or
Correct.
diseases that are... So the kind of symptoms typically are mostly the irritable bowel syndrome, the more severe irritable bowel syndrome symptoms like bloating of the abdomen, abdominal pain, and it can be the kind of pain that takes people to the emergency room. A lot of gas. Sometimes they don't have gas, and it actually just comes out in their breath rather than coming out, through the mouth or anus. Cramping pain, and either constipation or diarrhea or an alternation between the two. Heartburn, people with chronic nausea, people who waste away because they can't gain weight and they just keep losing weight. And then some systemic symptoms like muscle pain, like you would see in fibromyalgia, along with fatigue and headaches and joint pain. really common things.
Sure. Now, the causes, there's probably multifactorial, but if we could look at some of the more common causes that you see that contribute to this development of bacterial imbalance in the small intestine.
One of the things would be medications. So, for instance, proton pump inhibitors. Things like Nexium, the purple pill, Prilosec, all of those drugs that are very, very commonly prescribed that decrease the ability of stomach cells to make acid. Those drugs predispose patients to bacterial overgrowth because normal levels of acid and pancreatic enzymes and bile from the gallbladder and liver are essential to keep the growth of bacteria down, especially in the upper small intestine. They're secreted into the upper small intestine. Acid moves through into the upper small intestine, and it just keeps that area from overgrowing. That's important. Another drug that commonly we see starting this whole cascade is opiate painkillers, Vicodin, oxycodone, any of those kinds of drugs, tramadol. They tend to decrease the cleansing, so-called cleansing wave of the small intestine. And by either slowing that down or shutting it down almost completely, it allows bacteria to overgrow. And often we see that as the initial trigger. Sometimes it's also people taking antibiotics, especially for extended periods of time, like people that have acne and they get put on tetracycline or amoxicillin or some broad-spectrum antibiotic, and they're on it for months or years. Sometimes that starts it. So it's pretty common to see that sort of thing. Alcohol abuse could also start it.
You brought up something interesting about the opiates and so forth. So is that a motility issue? You mentioned the drugs do affect this cleansing cycle. So it sounds like you need proper GI motility and movement to keep things flowing through, or else you might create a stagnant state and allow these different opportunistic bacteria to overgrow?
Absolutely, yeah. The two really important factors for preventing overgrowth, one is proper motility, so things move from, mouth to anus and not the other direction, and that they move in a well-regulated manner. And the other is the proper secretions. The right type of saliva and stomach secretions and pancreatic secretions and liver gallbladder secretions. Very important. Also important is that the valves of the GI tract work properly, especially the valve from the small intestine to the large intestine, the ileocecal valve. A more recent study was very helpful in elucidating the fact that if that valve has poor tone and it's sort of loose and doesn't close properly, it will allow what's called ceco-ileal reflux. People think a reflux is just from the stomach to the esophagus, but there also very commonly reflux from the large intestine into the small intestine, from the cecum into the ileum. And that will allow those billions or trillions of bacteria from the large bowel to enter the small bowel. And sometimes that's the underlying inoculating cause.
Wow, that's very fascinating. And something I know for a long time that chiropractors have talked about is ICV valve manipulation and how that's the root cause of all these different things. And you mentioned, is this a recent study in a major publication that looked at the ICV valve dysfunction and linked with GI disorders?
Yeah, it was great. It was done at Johns Hopkins. They used a little device that the patient swallows. It measures pH and pressure as it goes through the GI tract. And so they were actually able to measure the pressure at the ileocecal valve and found that patients that had bacterial overgrowth had a significantly reduced tone in that valve, and it was more floppy and open.
Now, did these patients also have IBS, or is this just a random subset of the population?
I don't remember that they actually took it to that step, but they knew that the patients had positive SIBO tests versus patients that didn't.
Right. So I'm just thinking out loud here. There's other things that may affect sphincter tone, you mentioned, and motility. Stress, potentially, poor sleep, maybe eating at the wrong time, vagal nerve activation. Do you want to dive into that? And have you seen any research with like heart math or heart rate variability and yoga and how this may affect or improve the tone of these sphincters and improve GI motility?
I haven't looked into that. I haven't done that particular search, but it sounds like a good one.
Sure.
You know, the things that, there's a chapter in my book about ileocecal valve syndrome, and what I found putting that together and seeing patients is that the factors that seem to be most important are looking for any type of parasite overgrowth, looking for food sensitivities, looking for unresolved emotions. So, I mean, that goes to your parasympathetic tone and heart rate variability. Those seem to be really important pieces. And then just common dietary factors, like, for instance, the number one no-no food, if you want to be nice to your ileocecal valve, is to not eat popcorn. Some of the old writers on this, they made an analogy of popcorn is like razor blades going through the ileocecal valve. So, you know, there's certain foods that can be really irritating to the valve as well.
Interesting. I'll have to look more into that. Sounds fascinating. Let's talk about other foods that may predispose individuals to this bacterial imbalance. Like, I know fiber is very controversial. We know inulin and various prebiotics are beneficial for bifidobacterium and healthy genre and species of bacteria. But in someone that has these bacterial imbalances, that may be like putting kerosene on the fire. Is that right?
Yeah, I was listening to your fine podcast with Dr. Raphael Keller, and you know, he was talking about all these fantastic foods that have the fructans and the other fibers that are really helpful for feeding the bacteria. But in the case of overgrowth in the small bowel, and you've got, it's the same bacteria, you're talking about your normal flora, your friendly flora. When patients come to us, especially the ones that are severely underweight, at the point often they're disabled because no one's been able to help them with their abdominal pain and their tremendous fatigue and all this dysfunction that they have. Often those patients, when they come to us, they are eating about 5 foods. You know, it's sad. They're scared of food because it aggravates everything that they're experiencing. And one of the things that we try to do is explain to them and give them a nice detailed outline of foods and their fiber content, their, you know, with low FODMAPs diet, for instance, you know, low fermentable carbohydrate foods that tend not to feed the bacteria. You know, eventually we're going to want to feed those bacteria, but when the people are in that bad a shape, we have to educate them as to, you know, which foods are less likely to increase the growth of those bacteria until we can get a balance.
Sure. So in a sense, you're kind of starving out bacteria, so to speak, and in hopes to eventually restore some sort of normalcy amongst the microbes and where they are located?
I think it's pretty hard to starve them because even if a patient fasts, it's been shown that the normal flora can eat intestinal mucus because it's got sugars in it and they live on sugars. They can actually, if things are bad enough, say in the intensive care unit, often the normal flora will actually invade the mucosa and start to eat the mucosa. So I think it's pretty hard to starve them. They're smart and they know how to get food, and they're going to eat us and our mucus and our glycocalyx layer, you know, on the top of the brush border before they starve. So it's kind of hard to starve them.
So then you must use some other agents, whether it be non-absorbable antibiotics, or I know you like peppermint oil and some of the botanicals. So if we're not going to starve them out, what are some ways that we can help to rebalance the GI tract?
Well, we do decrease their food by using very specific dietary guidelines. But then we will, as you said, using non-absorbable antibiotics. The non-absorbable antibiotics are mostly prescription antibiotics, but of course rifaximin, neomycin, and the absorbable antibiotic metronidazole come in really handy for a lot of these people. But another option is to go the natural route and use the berberine herbs, things like golden seal, Oregon grape. We spoke early on when we were doing this, we spoke to Stephen Buhner, who's an expert on the herbal antibiotics, and he recommended 5-gram doses of berberine-containing herbs daily for at least a month to treat especially the hydrogen type of bacterial overgrowth. There are different gases produced by the different organisms, and the ones that produce hydrogen felt that they would especially respond to that. So we tend to use berberine herbs. We tend to use extracts of garlic, the allicin extract. We tend to use neem, the Ayurvedic herb, and we use not as much, but we do use some oregano. And occasionally we do use what you mentioned, which is the enterically coated peppermint. And that has the additional effect of being an excellent antispasmodic for the bowel.
Wow. When would you choose the rifaximin, for example, over all these wonderful herbs and botanicals that you mentioned? Is it patient specific, like what their preferences are, or how aggressive? Because it seems like if you're to put all these things together, oregano oil, garlic, peppermint, berberine, that you could really be almost just as powerful as some of these medications. But what have you found clinically to be more effective?
Well, until about 6 weeks ago, I told patients that the herbs haven't been studied, but our experience is they work just as well as the prescriptions. But a new study came out. It's a retrospective study that was done, again, at Johns Hopkins, where they have an SIBO center as well. And they like herbs there. And they did a study comparing their patients that were treated with herbal combinations versus patients with rifaximin. And they found that the rifaximin normalized the breath test for bacterial overgrowth, which is the most common test used, in about 36% of cases, a single course of treatment. And when they used the herbal treatment, it was 12% better. So it was about 48%. So now we tell patients, well, herbs are more effective according to research. But the thing is, you never really know what's going to work for an individual patient because you can't culture it. There is a culture method that can be done, and when we have patients that are going in for a upper endoscopy, the scope down the mouth, we do ask that their physician do an aspirate and get some material to do a culture, because that's really great information. Then we might actually know what bug it is. But normally the test is a breath test, which is a pretty good test to show what the organisms are making, hydrogen or methane, and that could be measured in the exhaled air. So because we're just looking at the gases that they produce, we don't really know, number one, which of the bacteria are overgrown, the normal flora, because there's so many, 400 or more species. And we don't know, well, we get an idea of how overgrown they are by how much gas is there. But we can't really do a sensitivity to find out, oh, this herb, it's sensitive to this herb and it's resistant to this one, or it's sensitive to this pharmaceutical and resistant to this one. So we pretty much have to just let the patient decide, give them the information and let them decide which way they'd like to start.
I see. So what I hear you saying is doing the endoscopy route, getting a sample is a lot more accurate because you actually have those bacteria and you can go to the lab and say, okay, this is going to be sensitive or resistant to X, Y, or Z.
Yeah, but the problem is that it misses. Doing an aspirate really misses a lot of the cases, so you can't rely on it. It's just a nice thing to do if the patient's already going in for an endoscopy. The reason being that the small intestine is at least 15 feet long, and you can only get into the first 6 inches or so, even less, of the duodenum, the first portion of the small intestine. At most, on little kids, sometimes they can get into the beginning of the jejunum. But still, you're talking about the first foot. And you got another 16 feet where you may have a bacterial overgrowth or other organism lower down. There's no way you could get an aspirate of that.
So the study that you mentioned at Johns Hopkins, I presume that was Gerard Mullen and his group?
Yes.
Okay. Yeah, I followed his work for some time. He's an excellent clinician, and I'd imagine you guys would be good friends and have a lot to talk about.
We're not friends yet. We haven't had that opportunity, but he will be one of the speakers at our second SIBO symposium that'll take place in June of 2015. We had one this January, and he couldn't make it, but he will be part of that next one, so that should be really good.
Oh, great. You brought up something that I would love to get your opinion on, and we talked about berberine at length up to now and how it changes the composition of the GI tract and the microbes, so to speak, in the context of SIBO. But we know berberine is really in the spotlight right now for how it affects blood sugar and maybe even better than metformin. Have you looked at the mechanism of action there, and do you think that's bacterial related? There's some AMPK mitochondrial functionality there, even the gut hormones. In your opinion, being an expert in naturopathic gastroenterology and plants and herbs and so forth, how do you think berberine is really affecting the systemic or enhancing systemic metabolism?
Well, I have my own little theory about that. Glad you asked. Mm-hmm. And here's what I think until we know more specifically. And that is, if you look at patients that undergo bariatric surgery, bypass surgeries, because of morbid obesity, a large majority of them are already diabetic. And the astounding thing about that kind of diversion of food, basically removing most of the small intestine, part of the stomach, and diverting the food in a poorly digested state until it gets to the lower small intestine, terminal ileum. That kind of diversion of food, so it doesn't pass through most of the small intestine, patients, even before they lose weight, in the first 4 to 5 days, often they are no longer diabetic. And the only thing that's really changed, grossly, is there's no food going through most of their small intestine. So I think if you take berberine and it affects your blood sugar, one possible way it's doing that is by changing the flora in your small bowel. And we know it does that because that's what we use.
Yeah, I agree with that. Well, there's a lot of research. I have a file on berberine, which I'd be happy to share with you. The incretin hormone. So you mentioned the diabetes that are pretty much reversed in the first 12 hours after bariatric surgery. And as you said, all the hormones are increased in the GI tract. There's compositional changes in the GI tract after bariatric surgery. But berberine has been shown to increase GLP-1 and CCK in overweight, insulin-resistant individuals. So very interesting. A lot of the bitter herbs have been shown to do that. Garlic has been one, but there's curcumin, resveratrol, a few others. So the incretin hormones, is that something that you've looked at?
I'm just starting to study them. Sure. And because I do a lecture on non-alcoholic steatohepatitis, the blood sugar-induced liver disease, and I'm just starting to look at incretins, so I'm kind of a newbie.
Sure. Well, I'm really glad you brought up bariatric surgery. I frequently do workshops and things for doctors, and I frequently ask, raise your hand if you think bariatric surgery helps your metabolism or helps individuals that get it, helps their metabolism by restricting the amount of nutrients that are absorbed. Raise your hand. And most people raise their hand. And I say, okay, option B is raise your hand if you think that bariatric surgery is not causing metabolic changes or weight loss through nutrient restriction, but through compositional changes in the gut microbiome and incretin hormones. And you get like 2 people that raise their hand. And so it's amazing that this literature is out there. It's been known for, I think, 4 or 5 years, the mechanism of action of bariatric surgery and how it works. And we now know there's many natural ways that we can improve the GI tract composition and the hormones, but we're still so focused on nutrient restriction and calories. Any comment?
Well, I'm sure that it's a little bit of both, but again, I think that there's a major shift in the bacteria when that food, especially the high carbohydrate type food, is not moving through there. And that's going to change the flora, and that's going to change the neurotransmitters that are being produced in the gut. And so I think it's a little bit of both. Mm-hmm. One feeds the other.
Sure. Yeah,
I'd like to mention a couple things that we have found. We call them little light bulbs that go off when a patient tells us something. It makes us think it has to do with bacterial overgrowth, and it's something that makes us want to test for it. Can I mention some of those things?
Oh, absolutely.
So the reason I came up with the idea of saying these are light bulb statements that patients make is that a lot of them, really, I think, a lot of them were statements that would make the physician turn off their brain and ignore it, maybe not even write down what the patient said, but they're just little pearls that are so important. And the reason that I think it would make, especially a natural physician, shut off and just ignore it is because they go against the worldview. You know, we have a certain worldview that certain things are good for us and other things make sense and others don't. So, for instance, one thing would be if a person tells us, you know, all my GI pain, my diarrhea or constipation, it got so much better when I took an antibiotic, say, for pneumonia. And wow, I was so much better. And then it's all started coming back within 2 weeks of finishing it. It was all back. That to us is a little golden little nugget that tells us that could be an overgrowth of normal flora. Mm-hmm. You know, that just got beaten down by a treatment that wasn't specific for it.
Right.
That's one thing. You know, most naturopathic physicians if they don't know what that means, they're going to think that doesn't make any sense because GI problems, you know, usually get GI side effects from taking antibiotics. Mm-hmm. So we won't want them to ignore that. Another would be when a patient says when they take probiotics, it makes their GI symptoms worse. And there we usually ask for more details and find out if it contained fructans like fructose oligosaccharides and see if there were prebiotics that were designed to feed the bacteria, which would feed the overgrowth. Another thing that we listen for is if a patient says, well, I've got irritable bowel syndrome, so all the doctors tell me I should eat more fiber, and every time I eat more fiber, my constipation gets so much worse. It gets intolerable, you know, so I can't eat fiber. And so that's another indicator because, of course, fiber is a food for the bacteria. Another kind of simple thing would be patients who say that their GI problems started when they took an opiate painkiller like oxycodone, you know, after a surgery or when they had a fracture or something like that. And the last one that I would mention that's pretty common is patients that have low iron, whether or not they're anemic, but they have a low iron level for months or years, and even taking iron doesn't bring it up. Those are people that we think about having bacterial overgrowth because iron is absorbed in the upper small intestine, and the bacteria, if they're overgrown, they like iron too, and they will take the iron before the patient can absorb it. The patient's chronically iron deficient.
Wow. Yeah, really good. I mean, I could see why, as an integrative and natural functional medicine practitioner, that someone said, well, when I take antibiotics, I feel better. When I take probiotics, I feel worse. You're thinking automatically like, you must be out of your mind because this is what I recommend. How could you feel worse? You know?
Right.
Wow. That's great. I think really good clinicians and astute clinicians like yourself, you're coming at this with an open mind and you keep hearing these things. You're like, gosh, there must be more to the story that I don't know about. Mm-hmm. You dig deeper.
Yep.
Interesting about the iron. I've been taught for a long time that systemically iron can be utilized to drive inflammation and is pro-inflammatory and so on. So to look for chronically elevated, maybe ferritin and altered TIBC and so forth. But didn't realize that the gut microbes were also utilizing that as well.
Yeah, and they can take B12 too. So sometimes it's more of a B12 deficiency that you'll find.
Interesting. So as we wrap up here, I would love to hear about your, and I think you kind of mentioned it, your diagnostic techniques and the breath test. If we could talk about the different gases that are produced, I should say, from the breath and how readily is that available? What should people look for when they are assessing SIBO?
Well, the breath test is done by having a 1 to 2 day prep diet, which has no fiber in it so that you don't feed the bacteria and no sugars. And then the patient fasts for 12 hours, and they do an initial breath specimen that measures hydrogen and methane. And humans can't make hydrogen or methane, but organisms in the gut can. And then they drink a solution that is a synthetic carbohydrate called lactulose. Humans can't break it down, but the bacteria can. And so it's total food for them. And then they take a breath sample every 20 minutes for the next almost 3 hours. And a graph is made of the hydrogen and methane levels at each 20-minute interval. And then we assess based on that whether or not there's overgrowth. The general rule is if the hydrogen rises from the initial level before the drink, if it rises after the drink by 20 parts per million, that's positive for hydrogen SIBO. If it rises at least 12 parts per million for methane, then that is positive for methane SIBO. And some patients have both. And an interesting and useful thing to know is that in general, hydrogen overgrowth, the bacteria that create that, tend to cause diarrhea, and methane tends to cause constipation. And if patients have both, they may alternate. So sometimes they're constipated, sometimes they have diarrhea.
Now, is it because those gases have some sort of effect on the GI epithelial cells, or why do you think that is?
On motility.
Oh, okay.
Yeah, they affect the motility.
How is this test different from, say, gut permeability tests?
Well, the gut permeability test uses mannitol and lactulose. It uses mannitol as a drink to check the absorption through the brush border, the normal absorption, and then because that's an absorbable sugar, and then it uses the lactulose because it shouldn't be absorbed. In leaky gut syndrome, of course, the lactulose will be absorbed more than you would expect because it goes in between cells paracellularly and gets into the blood that way and comes out through the urine. So that's a urine test. So it's looking at normal absorption through the brush border and in between cells. And one thing to know is that if a patient has significant bacterial overgrowth in the small bowel, they're going to have hyperpermeability. They're going to have a leaky gut, just almost by definition. And once it's treated effectively, most studies show that within 4 weeks, the permeability is normalized. Mm-hmm. So it's an important thing to do to take care of normalizing the flora in the small bowel in order to treat hyperpermeability.
Sure. So what I hear you saying is don't even really mess with the gut permeability test. Really figure out what type of microbes you have, because if you have microbes imbalance, like you said, you're going to have gut permeability.
Yes. Mm-hmm. An interesting thing, too, that I think your listeners could expand their thinking about this is if we look at the non-absorbable antibiotics that you mentioned earlier, rifaximin, for instance, there's only 2 FDA-approved uses at this time for rifaximin. One is traveler's diarrhea, and the other is hepatic encephalopathy, which hepatic encephalopathy is when a patient has liver disease that has affected the function of the liver so that the liver can't detoxify ammonia. And ammonia is produced by bacteria in the gut when patients eat protein. So it is a standard treatment for hepatic encephalopathy to give the patient rifaximin because it reduces the number of bacteria, therefore less ammonia is produced, and the patients stop being crazy. Because hepatic encephalopathy, it just makes them angry and irritable, and they just can't think.
Interesting.
So it's interesting that's an approved use. They're in the process of making the treatment of SIBO an approved use.
Wow.
But they're kind of related.
Mm-hmm. Yeah, it sounds like it from what you described. Fascinating. So as we wrap up here, I always like to ask folks 2 parting questions, and that's your favorite nutrient and your favorite or most effective lifestyle modifying factor. So that can be anything from stress reduction to yoga to heart math to getting off gluten. So what's your favorite nutrient, Dr. Sandberg-Lewis, and your favorite lifestyle factor that people should be modifying?
Favorite nutrient. That's like saying, what's your favorite color? I never know what to say. Yeah. But I think I would have to say I just make it a favorite food, and that would be sauerkraut. So much benefit there. I remember Dr. Bastyr, one of our teachers who died some years ago, he taught us that if a patient has extreme fatigue and just isn't getting over a bout of gastroenteritis, they have fatigue after that, the best treatment is just to take the juice of sauerkraut, real sauerkraut, of course, the juice, and every other hour take at least a teaspoon of the juice throughout the day until their energy comes back. And, because of its probiotic and its electrolyte content, it's just a terrific food. And your other question was?
The lifestyle So if there's just one thing, I mean, you can encourage people that you meet, whether it's in an elevator or patients, just change your life in one way, whether it's avoiding toxic relationships, eating with groups, chewing their food, just a simple lifestyle strategy, what would it be?
Well, you mentioned the first one, which was the one on my mind, and that is creating changes in the way your brain has processed trauma so that it no longer triggers recurrent trauma. Resolving unresolved emotions. And toxic relationships, are often a sign that the person is reliving some previously unresolved emotions and, recreating that stress for themselves on a daily basis. So really important, really important. And I think walking with the arms free to swing is probably the simplest thing that we use to help people process some of their stuck emotions.
Nice.
That's a nice, simple lifestyle thing.
Yeah, very inexpensive. The sauerkraut's inexpensive. We all have access, walking and so forth. So I really like that. Well, thank you so much for your time and sharing your wisdom with us. We'll make sure we have your link to your webpage there and your book and conferences and anything else you want to say before we part ways.
Well, I'd say that this was fun to do, and I appreciate what you're doing with this radio show because it's got a lot of advanced topics that are presented in a way that I think make a lot of sense to people.
Wow. Well, that means a lot, Dr. Sandberg-Lewis. I really appreciate that, and I'm grateful that you're able to make it on and share all your wisdom and knowledge, and hopefully people have some nice nuggets to go away with, and hope you have a fantastic afternoon.
You too, Mike.
All right.